in conjunction with the Vad Rabboni Botei Knesios of Agudas Yisrael, co-sponsoring this series. It's long anticipated, and it's been we've had requests, many requests, and a lot of planning to get this off the ground. Something that's a very tremendous need, and I just want to just be makar tov to Dr. Chaim Neuhoff. I'm not sure if he's here, and Krohn, who are the driving force behind our mental health Halacha division. It consists of a Sunday morning kollel, learning halachas that are negayah for mental health professionals, halacha hotline. We have seminars for rabbanim and shiurim for shiurei halacha for mental health professionals. And we thank the Avad Rabbanim, the Shiva Shlita, Shalom Kamenetsky, Rui Deutsch. This series is part one of what's Mitzvah Hashem going to hopefully develop into a more long-winded series of more intricate classes and presentations on many of the issues that Rabbanim need to deal with. This is a 4-part series just covering the basic ideas of basic issues and things that need to be known. The series is Lili Nishmas of David Shlomo Meir Zatzal, and as people in community leadership, mental health, I think it could be the most drastic change that Rabbanim and Paiskim Dayanim have come across over the years from the last generation. Something that the awareness has multiplied over the year. The frequency, the solutions, the whole industry has coupled. And we obviously we as a Bezdin, I think we see the more acute results of a lot of the mental health, and we want to take this opportunity to thank Rabbi Brudny for everything he gives us in the Bezdin area and the guidance that we have. It's we come across these areas very very frequently, and obviously the Shiva's participation is a testament of the importance of this this series, and we're. I guess I don't know if there should be cards for any questions. There'll be questions at the end of the session, Be'ez Hashem. So when people can write down, you can write down the questions that you have and pass them to the front. We can go through them. I'd like to be Chabad Goyin Rabbi Brudny Shlita.
First of all, I want to apologize to the Choshev presenters that I'm not going to be present when they present, and Abyssal Nish Derech Eretz, but I have a niece's Chassan in Brooklyn. So I came here, Mamash Shtickl B'Mesiras Nefesh, my niece is getting married in Brooklyn, and I came here, but I have to show up at least Epis. So, and I have another Parlor meeting for my Einikel's yeshiva here in Lakewood, so it's not min animus, but a hechrich lo yiguna. Just too short divrei akdama to why the Osiris that was Nesayir here to bring Rabbanim together and expose them to state-of-the-art input in the field of psychology and psychiatry. We have both tonight, and the little insights and input that we're going to glean from the mumchim agdechi gedolim in our kehillas in this field. and why should I say only in our Kehillas, there are nationally acclaimed leaders in their field, regardless of the fact that they're Yidden that are Charedim al Dvar Hashem, the Dvar Hashem. The first thing is that Rabbi Yerucham, in his Mechtavim, I think it's the third chelik of Das Chachma Musar, there's a letter there addressed to Reb Shimon Shkop Zatzal. When Reb Shimon Shkop was contemplating leaving Poland and migrating to the United States to teach American Bachurim so he could get a salary with which to support the Brudny yeshiva, and in this place he left his son-in-law to be the acting Rosh Yeshiva. Rabbi Yerucham is Yoitze Megidroi, he's writing to the Godel Adar, to the Godel Zkan Rosh Yeshivas, to exhort him and beg him, how could he forsake the Olam HaTorah and go to America? Even though it's the biggest L'Shem Shemayim of supporting his Talmidim with the salary, incredibly Gdusha and Tzidkis of Reb Shimon, aber wie kann das sein? So he says there that he was Makabel from his Rebbe, the Alter in Kelm, that the Yetzer Hara sometimes accomplishes more with misguiding, working to misguide the Gadol, the Einei Ha'eda, much more successfully than operating with different individuals, Milchemes HaYetzer. And he's being Meramis to Reb Shimon, but this is one of those instances where the Yetzer Hara orchestrated a whole Maaseh that Reb Shimon got an offer from a yeshiva in America to come and say shiurim, and they're going to give him a king's ransom with which he could support his Talmidim. Rabbanim are the Einei Ha'eda. I learned in a Lakewood where there were no Rabbanim, where there were no shuls. It was just, what's it called, the main shul on Madison Avenue. That's all there was. And Rav Blech just a little bit in very primitive quarters. That's all there was. And Satama just opened that shtibel on Forest Avenue. A shul, a Hamish Medrash, it didn't exist. And you're talking today, by the last time Levi Yitzchak Novoseller made that Shabbos last year, when he made that Shabbos for Rabbanim, there were over 200 listed Rabbanim, Talmidei Chachamim, that had Kehillas here in town. It's a Nayazach. Because the Rebbeinu Shalom was Magdim Refuah L'Maka. Klal Yisrael is falling. The Doros are getting schwacher. Chinuch Rabbanim is becoming so much more problematic. Shalom Bayis is becoming so much more. Shalom Bayis difficulties are becoming much more rampant. Mental illness, emotional disorders, v'chulu v'chulu. So how are we going to get to the Kehills? How are we going to get to the Am? How are we going to get to the Olam? Through Rabbanim. Yet Rabbanim grew up in the Dalet Amos Shal Halacha. Rabbanim grew up, many of us, we fought and fought and fought to stay in the Dalet Amos Shal Halachas and reject the alien influences of secular culture. And that transition, where we now need to come on to Chachma Bagoyim Tamin, that secular culture has developed the medical science of psychiatry, that secular culture has helped develop the umnis, the Chachma Bagoyim Tamin of psychology, v'chulu and v'chola nil v'meilov, is something that's not natural for us. And the Muscovician is a little bit to deflect. To see things not as black and white, Milchemes HaYetzer, but rather as a manifestation of something called personality disorder. Wo steht in Tosfos personality disorder? Wo steht in Chovos Halvavos personality disorder? Wo findet man personality disorder? Bring me as a Sach from personality disorder. So you have to be a novoin, a ish chacham v'novoin, to rise above it and say, das steht es. See that person? Das steht es. This is what we need. The Yetzer doesn't want us to internalize this. The Yetzer is very happy there should be more and more problems in Lakewood. He would rather that all the problems should be in Lakewood, in a makom that's Megadol Torah, that's Megadol Yira, that's Megadol values. Lakewood is Kodesh Kedoshim. Because Lakewood is Taka Kodesh Kedoshim, the Yetzer wants to do everything in his power that this Kodesh Kedoshim shouldn't bring us to Mashiach Tzidkeinu b'meira b'yameinu. One of the methods is create choili and make people skeptical of looking for help. Agam reshus nitten l'roifel l'rafos. Yeah, people accept we have a Messiah on physical choili, but on refuas hanefesh and choili hanefesh, he's matzliach to keep us skeptical. And this is what tonight is really about. The ma'argenim, both mitzad the Rabbanim and mitzad the Erlich Yidden, the professionals that got together, l'takes eitzah, is that we must put a stop to this. We must look for the signals, we must understand the signals, and we must unabashedly say, yes, the only solution is to get professional intervention of one kind or another. Das ist die erste Sache. Moshe Rabbeinu, the Raya Mehemna, Chazal teaches the Eibishter was Boidekim and David HaMelech in the Mechloye Satzoin. The Medrash Rabbi says in Parshas Shmois that by the Tzoin, the Moshe Yeroya is Tzoin Chosnoi. And he went in the Midbar with the Shepselach. And one Shepselah strayed. And Moshe Rabbeinu couldn't get the Shepselah back into formation. And it started leaving the pack, wandering away. And Moshe Rabbeinu chased after. And as Moshe Rabbeinu chased after, the Shepselah ran even further. Finally, after all this, they came to an Agam Mayim. And the Shepselah drank with terrible thirst. So Moshe Rabbeinu picked up the Shepselah and held him tight and almost apologized. I didn't know why you were running. I thought you were straying. I thought you were running away. Yet zeyich poshit, you were tzomel amayim. Ki'ilu Moshe Rabbeinu tzich gemont, also ich mashmer Chazal, tzich gemont for misreading the signal. And that's even on the first step, Rabbi say, on the rabbinic step, on the Rebbe step, on the Rosh Hashiva step. Pasha to see that a mikra azeh oime dershuni. The younger man comes over to me, starts talking against his wife. To notice that something's up with the younger man, before you take everything he says, like they say in English, hook, line, and sinker. Rabbim nechshalnu. I could say myself as chatoya ani masker ayoim. On the first day this happened to me, I didn't chap either. And on the first year it happened to me, I didn't chap either. But Moshe Rabbeinu is teaching us a gemishunetic lesson. The first story with Moshe Rabbeinu was the toyes kivayachol that he made with the Shepselah. Not that he successfully chapped the Shepselah. He made a keilu a toyes, if you're allowed to say legabi Moshe, such a zach. He grabbed the Shepselah and entschuldigt sich for the Shepselah. I thought you were straying from the pack. No. I didn't understand your signal. You were thirsty. Die zwei Oros I wanted to share with you. So the Rebbeinu Shalom will help in Yehi Rotzain. Shetishru Shechina b'maisi yadeinu, and we should be able to come to a different level in our shlichus that the Eibishter gave us the good fortune to be his shluchi derachmona in being royes soinoi, the Toin Kadoshim of the Eibishter. We should do it bechachma, bebina, ubahaskel, and to be zeicher constantly to be marbek v'it shemayim and helping Yiddish kinder. Thank you.
Yasher Koyach Rosh Yeshiva. Yasher Koyach. I'd like to call upon Dr. Jonathan Schwartz. Rabbi Dr. Jonathan Schwartz is going to introduce the series, and Rabbi Dr. Schwartz was very involved in creating the curriculum, and the curriculum, the second part of the curriculum, which is going to be more extensive, which will start sometime after the summer. We much appreciate his involvement, and we'll ask him to introduce Dr. Glenn Hirsch.
Thank you very much, Kvod Harav. I also want to thank the Beis Avad for taking the initiative here. There's a tremendous need. I think we've talked about it as mental health professionals, and to realize and to see all the great Gedolei Rabbanim from all over who are here, and all those who have joined in all over Zoom, it's really something very impressive. There is one word of Hakdama I just have to offer. There's a famous story that they tell about somebody who asked some of the Gedolim in Europe what the job of a Rav is. So they went to Rabbi Rafal Shapiro, supposedly, and he didn't answer the question. Then they went to Reb Chaim Ozer Grozensky, and he said the responsibility of a Rav is to teach Torah, to make sure that you make up the elements that are necessary for kashrus, for an Eruv, and for a mikvah, and of course to be able to be Goma Chesed for Yisomim and Almanos. I think that's a pretty good description, to a certain degree, of the wide degree that we engage in as Rabbanim, no matter where we are. The Aruch HaShulchan was asked, and he said that he understood the job of a Rav is to turn around into Paskin Shilas. But when they went to Reb Chaim Brisker, Reb Chaim said the job of a Rav is to go ahead and be Goma Chesedim Ha'aniyim V'Anitzrachim. Rabbosai, on behalf of the mental health professionals in our community, I want to thank you for being Mekayim Shloshta. You're turning around and being here in this instance to be able to make sure our communities move well, to make sure that we'll be able to have people to help us with our Piskei Halacha, and also at the same point in time to help us in all of our missions, all of us as community people, to be Gomli Chesed, and to have the hadracha from you is something tremendous, and we greatly appreciate it. I'm only here for a very short, brief point tonight. I'll be back in 2 weeks to talk about the issues of anxiety and obsessive compulsive disorder. You really came to hear Dr. Hirsch. But in order for us to have a basis for a conversation, we need to just understand what goes into mental health treatment. Very often you just hear words and they all just sound the same, and I just thought it would be helpful if for a brief couple of minutes we can turn ahead and just talk a little bit about what it is that we do and who does it for us. If you can move it ahead one for me. I don't know how to do that. So some of the basic issues that I think come up when we deal with issues in therapy, the first major issue I think we see in our kehillas is the question of the stigma that people have. Think about it in your own community. If somebody needed to go ahead and find help in mental health, the first thing that we hear very often is there's going to be a tremendous stigma attached. I think one of the big roles that Rabbanim get to play is that we can sort of help mitigate some of the stigma. If I could figure out how to move it to the next one, I could use the help too. The second issue I think that comes up all the time is the halachic inyanim. There are going to be a tremendous number, just in these 4 weeks, you're going to see just exactly what we come up with and where different channels are going to come. You're going to have them with Dr. Hirsch in a couple of minutes, just to be aware and to have people that we we want to be able to lean on as mental health professionals that your balabatim want to deal with when they're dealing with very important issues. We need to understand there's a tremendous amount of halacha that comes into play, and how the halacha is delivered, and the fact that it's not the job of a mental health professional to paskin shilas. We need the guidance, we need the partnership, and that's the role that, in addition to some of the other ones, that we need a tremendous amount of help with. Let me add, if you can. There are a tremendous number of biases that people have towards mental health treatment. I'm not going to go into all of them now, but there are people who have certain machshavos that, different types of therapies, depending on who's involved in them, are going to raise certain questions. This must be usser. That must be a completely off the wall. This particular style of therapy is no good. If we go here, it's going to cause a tremendous amount of backlash. How's my neighbor going to imagine how I look at the situation? So there are biases. And again, Rabbanim, sometimes if I'm sitting with my Rav, and my Rav can say to me, listen, I know what you're talking about, I'm aware, and I'm still telling you to go along with it. I still think it's what you need. You don't understand the tremendous amount of comfort you're offering somebody, whether it's somebody who's looking for himself, for a spouse, for a child, for a parent. It happens every day. And from the ability to talk from knowledge, Rabbanim are the best because they're out there. There's no stigma there. And the Rabbanim are able to help us. If you shift ahead, please, for me. So among the other roles of Rabbanim, and this is a limited list, I think a Rav has to understand that he has, first of all, the responsibility, what I call the burden of caring. He gets to show that there's people out there who care. He has the ability to provide support directly. We're going to see together where we partner a lot. I know in 2 weeks' time we'll talk about it very hands-on when we talk about anxiety disorders and obsessive compulsive disorder. But I'm sure even still yet to go tonight, Dr. Hirsch will give us an example when we're dealing with psychiatry, when we're dealing with medications. And then there's just the side support that the Rabbanim have the ability to provide, where somebody needs an encouragement, an opportunity, a chance to see. I call that the ancillary support. Not all issues belong only in a therapy room. And so therefore, a Rav has the ability to provide something a therapist is not supposed to, spiritual guidance. Sometimes a Rav has an ability to provide referrals. And I think it's next week we'll have the chance to hear from Rabbi Babad. And Rabbi Babad will show you the process and what goes into making a referral. But people don't necessarily first reach out to Rabbi Babad or to Rabbi Sutton, who's here. You have to first know where you're turning and what you're turning for. And usually the first line of defense is a Rav. And knowing what goes into an ability and where to turn and how and understand that, it's not the stuff that we sat down when we learned in Kollel and we're learning Yeridea, but it's certainly a role that we play. Knowing what's out there in the community, Chazdei Hashem Yisbarach, there's a tremendous amount in the community that's available, but knowing where to look is tremendous. But at the same point in time, a Rav needs to know when he's in over his head, where he can turn beyond, and also where he can turn around and follow up. Please proceed to the next one for me. So who are we referring to? So the first thing I think you need to understand is just there are medical professionals. Not all people in mental health are the same. Dr. Hirsch is a medical doctor. I am not. What he is a psychiatrist. Psychiatrists dispense medication where appropriate, which I'm sure you'll get to. Psychiatrists have gone to medical school. They have training, and most don't necessarily have the largest amount of therapeutic exposure in comparison to some of the other people we'll come across. Just the name of the game. It's important to know, even if he's the top of the totem pole, doesn't mean that that's where you're referring all the time. I don't know how many marriage cases you see, but if somebody's calling for a couples therapist, and you say to yourself, well, wait, he's a psychiatrist, he's gone to medical school, maybe he's the best one out there, probably not the best choice necessarily, maybe for you, Dr. Hirsch, but not all my colleagues who are medical doctors are going to be the ones to step in under that circumstance. I am a clinical psychologist. I get to call myself doctor. It makes my mother very happy. I don't know if that's always what she wanted. I use it as an excuse to explain why I have bad handwriting, because I didn't want to go to medical school to explain it that way. There are two levels of psychologists. Some are master's level. That means they've done a certain amount of training. Doctoral level psychologists have done more hours of training. They've done more studying. Very often psychologists have concentration in therapeutic areas. That means that when you're dealing with a psychologist, he may not be a catch-all doctor. For instance, I don't treat addictions. I'm not very good at that. I have a certain area where I think I spend most of my time. I'm involved more in the anxiety disorders and obsessive compulsive disorder. You may like talking to me. We may have a very good sprach, but if you call me on the phone and you say to me, I'm dealing with an addiction case, I want you to see somebody, I may tell you, listen, here's a good number for somebody who deals with addictions. Dr. Newhoff has many, he's much bigger expert in many more areas. But part of the art of being able to have a name is to know not only who you are, and but where your limitations are. And that's important for us to understand. The other thing that psychologists are known for over, say, social workers and mental health counselors, who are also very well trained and tend to be specialized, is the fact that psychologists uniquely tend to conduct something called psychological testing that can come up in a whole host of different instances. Sometimes they're utilized for legal reasons. Sometimes they're utilized to help us with adults who may be experiencing different, what we call neurological issues, neurocognitive, neuropsychological issues. Sometimes they may be involved in dealing with children and helping us figure out what's best to deal in terms of children. Not everybody needs to go for psychological testing in order for them to get help. But to know when you need somebody who does testing, you're likely to look for a licensed psychologist. Social workers tend to be master's level. They also engage in something that psychologists and psychiatrists don't, and that's case management. And it's very useful to know that, because sometimes you have a whole chunk of different issues and different people who are working things out together, and knowing that you have somebody who sort of quarterbacks the entire process, that's an important issue. And it's an important thing to know where to turn. And there are a whole host of mental health counselors, et cetera. I feel a responsibility to highlight that, at least in my humble opinion, I am very makpid for myself, at least, never to refer to somebody who's not licensed. Because licensure guarantees one thing for you. It means that there's mirsus. It means that if I do something wrong, I get schlepped in front of a board, which helps to make sure that certain boundaries are going to be kept, and you can expect certain responsibilities from me. And so when we're dealing with whichever mental health professional we are, one of the questions I like to make sure when I'm making referrals, and I believe Relief will tell you, I think Rabbi Babad will tell you that he's very makpid, only to refer to somebody licensed. Please move ahead. I'm sorry, Dr. Hirsch, I'm almost finished. All right, so give you a backtrack? Yeah. So what are we referring people to? And it depends. I guess you know your aleph base. The first thing you have to know is, are we referring somebody to medication management? I got a call on my way down from central Jersey, I guess sort of northern-ish Jersey, from somebody who called me on the phone in the middle of Maryland, who's really from Florida by way of Cleveland. And he's having trouble with his medication issues, and he wanted to discuss it with me. And I said to him, no, you need to discuss it with your doctor. I can't give you advice. That's not my area. I need to turn to Dr. Hirsch or to whoever the medicating doctor is. That's where you need to go. If you're in an emergency state, let's figure out where we can get you to go. As Rabbanim, we need to know. If somebody is dealing with a bipolar break, where are we going? Please make sure you know who's who and where you're heading with them. Sometimes things are intense, and we need to be able to refer it for hospitalization. Not every situation requires hospitalization, but when you're dealing with certain extremes, and unfortunately in our community, we do have them. Suicidality comes up sometimes where somebody just can't hold on to himself. We're afraid that somebody is in danger. A couple of years ago, I was sitting in my house on Shabbos afternoon, and one of the Rabbanim from my neighborhood came knocking at my door. His daughter-in-law had a break, and they wanted me to get involved. I wanted to know, do they have to call Hatzalah? I said, if you're asking the question, I'm pretty sure the answer was yes. But the situation was intense, and there is a road that comes down, and you need to know in those situations there are different types of hospitalization, so to speak, and you have to know the steps, and it's important to understand them. There's inpatient, which tends to be a little bit more short-term for stabilization. There's a partial hospitalization program where it's stretched out a little bit longer, a little bit more offered to sort of help deal with the situations. And then there are a number of programs, even I'd say a little bit more of a step down, which are there to help somebody in their tough spots. Fortunately, as things are going on the outside community, sometimes they seep into ours as well. Drug rehabilitation is an area that we need to know. Sometimes we also have to refer to, and we want to know where are the right places to go and sometimes how to help people work through that. And then there's the classic outpatient therapy, which we all have heard of before, but there are three different subtypes, I think, come to my mind. Issue number one, there's a classic individual, one-on-one. Then there's what we call couples or family therapy, where a therapist might be working with a couple or with a whole family to help them in their situation. And sometimes there are group therapies, which, just to be perfectly straight up with you, our frum community is not very involved in tremendously. When not online, very often the frum community tends to be a little bit more reserved, but depending on where we are, we're finding people and groups, and depending on the condition, where people are actually stepping out, and there's a tremendous toelis there as well. Can you move forward, please? Okay. Maybe I can move forward. Maybe I can't. Okay. I guess I'm doing the solo. So some of the things you want to be able to understand. There's an article that just came out today in one of the secular journals as to whether gender makes a difference. Who you're referring to a man or a woman to a woman? Is it better for one way or another? I just want to point out that that's an issue to be brought up in therapy. It's an issue that Rabbanim deal with all the time. That's not a question for me to deal with here in this particular hat. That's a question that I think very often, as Rabbanim, you're going to be brought. It's going to be brought and discussed with you. There's a discussion of frumkeit. I had a person who trained me who was a non-frum, but very Jewish-oriented individual. One of the people who was involved in my training. He treated a lot of frum people. On the other hand, I like to think I'm frum, and sometimes people seek me out, or Dr. Neuhoff, or Dr. Hirsch, because they know that we are Shomer Shabbos, and they feel that there's a certain comfort level. These are issues that you have to be aware of. How much experience does a person have? I talked to you about the licensed versus unlicensed. Rabbi Babad will talk to you a little bit about whether we refer to a specialist versus somebody who's just a generally good therapist. Which of the two systems do you prefer? He'll share that with you. And then there's the big question of therapeutic orientation, which I'll just put on the table briefly. It's the style that the therapist tends to use. And it ranges from, and I tend to think in my head a little bit more in a model called CBT, cognitive behavioral. Very often people tend to like that style. You'll hear people talk about psychoanalysis. You'll hear people talk about some of the new stuff, ACT, which is acceptance and commitment therapy, EFT, just the emotionally focused therapy. There are a whole bunch of different styles and letters, and there's a place to turn to, and you can always reach out to whomever you want just to get a little bit more of a perspective. And one of the things I think we're hoping to generate through the program is that there'll be people that you should be able to feel comfortable picking up the phone and saying, okay, this person has been suggested to go for kinetic therapy. I got a call from Yerushalayim about 4 or 5 years ago from a guy who said to me his wife is involved in kinetic therapy. I spent a lot of time figuring that out, trying to figure out why. In order for her to deal with her anxiety, she had a lady who was coming over and fixing her head in certain positions and touching her in certain ways, and that this was supposed to work. I don't think the literature that I looked at tended to suggest that that was the way to go. That's not a knock on kinetic therapy, it's just a knock on that particular situation. I didn't think that that was an orientation I was going to highlight, and I had to politely plead ignorance together with many other people. It's important for us to understand who's who and what's what. One more, please. Okay. So you're going to have to keep scrolling down because it highlights. Thank you. Shkoyach, shkoyach, shkoyach. Okay. So just to end off, the Rashiva mentioned the one point I wanted to close with. The Rashiva finished with the understanding that there are people out there. You're not alone. Rav Moshe already identified this many years ago. It's in the Gris Moshe or Deich Chelik Beis Siman and Zion. Rav Moshe was concerned. Someone was concerned about referring to mental health professionals. This is going back to the 80s, if I'm not mistaken. And Rav Moshe said, if you can turn around and look for therapists who are Yirei Shamayim, it will help within the process. Chazdei Hashem Yisbarach. I am here to tell you, we have the therapists. What we have now, as a result of the program that we're putting together, is that we have an avenue for the partnership, and above all, the avenue to be able to look up and be able to get our own influence from you, the Rabbanim. And I thank you for that in advance, and I look forward to the continued partnership with you together. Be'ezus Hashem, in 2 weeks, we'll talk a little bit more in detail about our specific areas, and we'll see how partnership comes together. Thank you very much.
Introduce Dr. Hirsch, just to give one word of thanks for the efforts involved in coming here, and it's his words are, are highly anticipated and professional of very great stature. Thank you very much.
Thank you very much, everyone. The slides will come up in a moment. Yes? Do I do it? I want to begin, while they're working on the slides, I guess, to address the issue of stigma. All right? I mean, you've heard about it. You're hearing patients and folks do not want to come for treatment. And part of the reason for that, of course, is they think they're unique. They're alone. No one else is going through what they're going through. And I think we have to help people understand that mental illness is common. In fact, throughout the world, it is the greatest cause of lack of productivity and lack of functioning. The top cause of that is depression. Anxiety is the second. And so, I give you just a quick anecdote. I have been involved over the years with many potential shidduchim. And right, so I see a young man or a woman is coming into the pasha. Can you speak to the potential, my future in-laws, they have lots of questions. And right away I get, what medicine is he on? He's on Zoloft. What dose? 50 milligrams. Well, why Zoloft? I said, you sound like you know something about medicine. And sure enough, they do, because there's someone else in the family like that. And that happens over and over and over again. So everybody who is going through this illness sees themselves as being alone, and yet it's everywhere. And so one of the things we need to do is let people know that they're not alone. Okay, I'm going to have the same issue with you then, right? I got to point this somewhere, right? Okay. Part of the issue, of course, is how much do we want to use medicine? I want to talk about that today a little bit, but first to that, before I do that, next slide, please. Next slide, we'll skip this for now. One of the other issues of stigma and myth, if you will, is that there's something different and unique about psychiatric illness versus a medical illness. And part of that is, when we see someone with a medical illness, our first thought is to rush in and help, be supportive, be gecholim, right? When we see someone with a psychiatric illness, we back off and we blame, right? We see a child in the grocery store screaming their head off, bad parenting, right? We see a person in Beis Medrash pacing back and forth, and we say, mishigas, right? These are illnesses not different than any medical illness. You say to me, okay, medical illness is a blood test. And yet there are many medical illnesses where there is no blood test, there's no x-ray, there's no nothing. And we believe headaches. You have a headache? We can rule out there's no brain tumor. But after that, it's based upon the symptom picture. Restless legs, irritable bowel, pain of all sorts, lower back pain. How many people do you know have lower back pain? The doctor takes an x-ray and says, I see a slipped disc. And yet a whole bunch of people who don't have pain have slipped discs. There's no test for it. And the same with most psychiatric disorders. And then, of course, their disorders have levels of severity. We sometimes think, I see today he's having an issue, but tomorrow he doesn't. That means he's in full control of it. That's not a real disorder if he can handle it. If he doesn't have the problem today, if his behavior is not problematic, if he doesn't wash his hands 50 times when he's in my house, but in your house he does. And yet, think about it. Does that mean the asthmatic who is not wheezing today doesn't really have a real illness? He should control it. So really no difference. We see that with blood pressure. We see that with ulcerative colitis, autoimmune disorders, pain. If I don't have pain on Monday, but I'm pain on Tuesday, does that mean I really don't have an illness? It's not a real illness. I can control it. You should just get up and get out of bed. The same thing with psychiatric illness. These are chronic illnesses that wax and wane. The other thing about all medical illnesses is, one, they're rooted in biology, right? They're all, whether it's a heart condition, a condition of your kidneys, or a brain condition. This is all biological. That doesn't mean that the environment doesn't play a role. Again, the person with asthma who walks into a construction site is going to end up potentially in the emergency room. So the environment makes a difference. Whether it's the external environment, the internal environment, we can worsen or improve symptoms based upon how the environment reacts. We'll talk a bit more about that. Next slide, please. So while I tell you that the brain is what we're talking about when we talk about psychiatric illness, it's not so easy to evaluate the brain. At the end of the day, the stomach does one thing. It digests food. The heart does one thing. It pumps. It's like a water pump in your car or your dishwasher. It's a little bit more sophisticated, but it does one thing. The brain does dozens, hundreds of things. And there's no way of, and I don't think any of you want to volunteer to say, can I do a brain biopsy? Oh, no, I'll stick another needle in your brain to see where we can find out the issue. So we don't have the sophisticated equipment yet to do this. But if we take 1,000 people with OCD and 1,000 people without OCD, we see very clear differences in their brains. Looking at very sophisticated, what's called functional MRI or PET scans. But that's an average. We can't use it to diagnose an individual, which means we don't have the best understanding of the biology of this disorder. In the same way, we don't have the best understanding of lots of disorders. You'll hear over the next several weeks the term DSM. DSM is a diagnostic manual that lists all of the illnesses that psychiatrists and psychologists and social workers, mental health practitioners look at as a way of communicating information. Because when Dr. Schwartz says to me, OCD, I know exactly what he means. I have that picture in my head. I know the diagnosis and the criteria that he's talking about. So it's a way of communicating, but it's not telling me about the biology of the disorder. People talk about chemical imbalance. That's a cute way of saying we don't really know what's going on. So just be aware of that. In the same way, I don't really know, and most, when someone has dementia, right, Alzheimer's, we don't know what causes Alzheimer's. We don't know really what's going on. We think this year it's that, next year it's that. Next slide. So this is just to tell you that medicines work in the brain, and it works in an area of the brain called the synapses, the two places where two nerve cells connect, if you will, and there's a space where we can put chemicals in, and there are, in this very complex pictograph, 10 different ways we can enhance, change, adjust chemicals in the brain by use of medicine. Next slide, please. So before we even talk about medicine, let's talk about what we need to do. You can't start treatment without knowing what the problem is, right? And just because the patient comes and says, I have pain, that's not, I can, on an urgent basis, say, well, take some Tylenol, take 2 Tylenol, call me in the morning, but I need to understand what's going on. So I need to evaluate that. So if it's pain in which I cannot do a test, I say, when does it come on? Under what circumstances? Where around your head is it happening? Does it happen if you're hungry, not hungry? When it comes to mental health conditions, I'm going to ask all of those questions, and the more people around that individual that I can ask questions to, the better. So anytime I see a child, I'm on the phone with the Rabbi. I'm on the phone with the pediatrician. I have the parents in the room. If I see an adult, what I always like to say is there someone I can talk to? If it's a young adult, can I speak to one of your parents so I can get some history? I want to know how they view you, right? They come in and they have one story, but that story is bigger. And when I do an evaluation, I want to understand 4 areas. One is what they are like in terms of their responsibilities. Whether they're learning in kollel, are they learning? Whether they're in yeshiva, in elementary school, or they're at work. How are they functioning in that sphere? The second, how are they functioning with their family, right? How are they functioning with their peers? Third, fourth, how they feel inside. So there are 4 quadrants I think about. Once I have all that information, I make a diagnosis. Then I have to decide what my treatment options are. So let me give you an example here. About 6 months ago, I go to my internist, PCP, all kinds of fancy titles, my doctor, plain and simple. He takes my blood pressure and he says, you know, Glenn, your blood pressure is running for the last 25 years, 110 over 70. It's now 130 over 88. I don't like that. We should start thinking about doing something about it. He says, if it was 150 over 90, I might be thinking about sending you to the hospital, but I'd certainly be putting you on medicine immediately. But it's on the mild end. So I'm going to suggest therapy for you, right? His form of therapy is not too different than what Dr. Schwartz and others will do. It's either making changes the external environment or the internal environment. So he says do several things. First of all, cut out the corned beef and the pickles. You got to cut out salt. The second is, you know, lose a little weight. The third is, I want you to exercise. Okay? And part of that takes some mindset. He says, you know something, I want you to see a dietitian, a coach. Sometimes the therapist is simply a coach. Simply. I mean, it's complex. Right? I come back 3 months later, and one of 2 things happened. Right? Either he looks at me and says, you're looking great, you must have taken my advice. Or he says, looks like you haven't taken my advice. So let's take the second round. I haven't taken his advice. And he's going to encourage me, try again. Or he looks, my blood pressure says, time for medicine. The second is, I did take his advice. He says, you're looking great, you're looking fantastic. Unfortunately, it hasn't changed the blood pressure. It's time for medicine. Right? And so medicine has a role, but it depends upon the level of severity when we move into that role. Right? How impaired is the functioning? If I see a young man who's not getting out of bed, I want to do something immediately. If I have a man who's struggling and maybe is getting up late and is having other issues, I say, let's start with therapy. And the good news is I'm just a pill guy. But Dr. Schwartz here, he's a therapy guy. So I can say, you start with him. Then you call me up in 3 months and we'll see where we're at. Next slide, please. Okay. So one of the other myths, if you will, is these medicines, they're new, they're experimental, you know, I don't know anything about them. I want to give you a little bit of history of medications. So the first medication that ever comes to market is aspirin, the granddaddy of medicines. And we think about aspirins as a pain reliever. But aspirin has many functions. So I'm cluing you into the idea that when we talk about in medicine, often the first, if you will, name given to them is the one that sticks, but it has other functions. So it reduces fever, It's also used for some folks with heart disease taking a low-dose baby aspirin. So in 1921, we have insulin. In 1936, the first paper in a journal is published using stimulants for kids that we now recognize as having ADHD. In 1942, penicillin first comes to market. In 1954, antipsychotic medicines come to market for the first time, and changes a whole way we think about patients who have psychosis. Those are folks who have a break with reality. In 1950, lithium is first used. In 1970, it becomes available in the United States, and it becomes a major treatment for bipolar disorder. In 1957, the first antidepressant comes to market. In 1988, Prozac comes to market. So these are medicines that have been around for 50 to 100 years almost. Nothing new. Next slide, please. The other myth, they're not so effective, they don't really work. So on the right side in blue, you see little round circles, and they represent the medicines we have in mental health. On the left side, you're left. I have trouble with my right and left, I'm sorry. But on the left side, you see the clear circles. They represent medicines in general use for all kinds of conditions. And going from the bottom to the top is how effective they are. And what you see is, essentially in the middle there, is a whole bunch of medicines that are moderately effective. But psychiatric medicines and general medicines are about the same. There's some that do really poorly, and there's some that do extremely well, and some are just about average. And if any of you have a chronic condition, know someone with chronic conditions, kidney disease, heart disease, high blood pressure, you know that sometimes it takes more than one medicine, a second medicine or a third medicine to get things under partial control, not always full control. So again, psychiatric and general medicine, not very different. Next slide, please. And as I hinted before, medicines often have one use, and this makes people a little bit kind of very uncomfortable. I'm using a medicine that's labeled by the industry as antipsychotic for depression. Or I give someone Zoloft for anxiety, and they say, well, you know, I think I'm also a little depressed. Shouldn't I have an antidepressant? And these are medicines that tend to be versatile, and that means we often use them for multiple conditions. And the reason for that are complex and probably have to do with some overlap in some symptoms. So for example, the latest, everybody's heard about Ozempic, right, for weight loss, but it's a diabetic medicine, right? Propecia is for hair loss and prostate conditions. Wellbutrin is an antidepressant. It's also used for smoking cessation. Amitriptyline is an old-fashioned antidepressant, also used for migraine and pain. So I want you to keep that in mind, because people will get, you know, why are you giving me this medicine? That's not what I have. Next slide. So here's a list of all the disorders that may benefit from medication. Again, the FDA, the Federal Drug Administration, requires a pharmaceutical company generally to get a medicine to market. It has to be for a specific condition. So I can only market a medicine for ADHD. I can't market it for a symptom like impulsivity. But ADHD medicines can help people who are impulsive who may not actually have ADHD. So I want to keep that in mind as well. But ADHD, depression, all forms of anxiety, Tourette's disorder, bipolar disorder, psychosis, autism, cognitive impairment, and then there are a couple of substance abuse, and then there are two main areas that that drug companies have been able to market for a symptom. One of them is pain, right? And so we have a whole host of medicines that are for pain. Pain is a symptom, it's not a disorder. And then the other is for the irritability and aggression in children and adults with autism. Next slide, please. So these are the main classes of medications. And we're going to go through each one in a moment. But ADHD medications, which include what's called stimulants and non-stimulants, antidepressants, which also cover anti-anxiety and anti-OCD and trauma, mood stabilizers, which are also for bipolar disorder, antipsychotics, which are used also for enhancing antidepressant effect and anti-aggressive behavior, sleep medicines and anti-anxiety medicines used for short term, and cognitive enhancers that are used for dementia, which I won't touch upon much at all. How much time do I have? What's my... Good. I got a few more minutes. Let's go to the next slide. This is one of 2 pages of stimulants, and I'm showing it to you just because it's very colorful. What I want you to be aware of is that if I'm the Hirsch pharmaceutical company and Prozac is out there and it's a blockbuster medicine, I have no interest in making something unique. I'm going to look at it and say, how can I make it close enough to be exactly the same, but I can patent it myself? And so stimulants, which are used for ADHD, for folks who have traumatic brain injury to help them focus and be less impulsive, I have 2 basic classes, methylphenidate and amphetamine. For 80%, for 70% of people, children and adults, every one of these medicines will do the same job. So when somebody says, I think Concerta is the best, I think Ritalin is the best, I think Mydayis is the best, I think Adderall is the best, I think Vyvanse is the best. I think. But there's no evidence that one is better than the other. For an individual, one may be better, but I can't predict ahead of time. I can't say, oh, you need Adderall, or you need Vyvanse, or you need Concerta. There's no evidence that I can match medicine to individual. And again, for 70% of people who have ADHD, it's going to work equally well. Next slide, please. This is the second page of a whole host of medicines for ADHD, all having the same chemical. It's like taking paper, making tissues, and saying this is Kleenex, this is Cottonelle, this is Kirkland brand. Okay? You can blow your nose at all of them. Next, antidepressants. So on the left-hand side, you have 5 antidepressants, and you'll notice SSRIs. SSRIs stand for specific serotonin reuptake inhibitor. It's just a fancy way of saying this is a medicine that affects a chemical in the brain called serotonin. There's nothing unique about any one of these. Prozac, Paxil, Lexil, Lexapro, Zoloft. Why I choose one versus the other? There may be small differences. I may choose Prozac because if I give it to a teenager or an adult who is forgetful, Prozac is in your system for several weeks. At the same time, something like Lexapro doesn't interact with other medicines. So if you have lots of complex medical conditions and taking lots of medicines, I may want to use Lexapro. But from an effectiveness point of view, for depression or anxiety or OCD, they're all the same. But they're not, don't work for everybody. And so I've got a whole list of others that I can use, right? And I can go down the list and say, well, we're going to try this. You'll notice the next 3 are what's called SNRIs, and they're all very similar to each other. And then we have a bunch of others, including some that have been around for 30 to 50 years or so. What I'm really pointing out is that I don't want, and I'm not asking you to tell a possible individual, you should be on this particular medicine. Because there may be a whole host of reasons why that's not the right medicine. But also, I don't want people to get, this is the medicine that's going to work for me. Right? And I can't tell you how often I get, you put my father on Prozac, but my father-in-law is on Zoloft. Why didn't you use Zoloft? Right? And the answer is, I chose Prozac and Dr. X chose Zoloft. But there's nothing magical about either one of them. Next, then we have bipolar disorder. Bipolar disorder is a disorder of highs and lows, And in the highs, you do things that really are out of character dramatically. In the lows, you look like depression. Lithium is the mainstay, but there are a whole host of other medicines that are seizure medicines that have also been helpful. I want to spend a moment with lithium, because lithium is rather unique. Lithium is actually one of the few medicines that is specific for bipolar disorder and really doesn't treat anything else. If someone responds to lithium, then they have bipolar disorder. If somebody responds to Prozac, they can have depression, or they can have anxiety, they can have OCD. But lithium is unique. The other thing about lithium that I want to point out is that lithium is natural. And people like natural, right? And so if you recall in high school, when you learned about chemistry and you saw the table of elements, near 93 elements, oxygen, wonderful, natural. Hydrogen, wonderful. Carbon, we're built of carbon. In there is lithium. In there is also lead. In there is also plutonium. So natural does not mean healthy, no matter what AMI magazine says. Next. And then we have antipsychotics. And antipsychotics are heavy-duty medicines. And they're used for schizophrenia, for bipolar disorder, and sometimes to help antidepressants work better. The first generation are rarely used nowadays because it had a side effect that can result in, after decades of use, a movement disorder of the mouth and body. And so we have the second generation, which are almost exclusively used nowadays. Not any one of these is better than the others. They all have the potential to cause weight gain, and that's our biggest concern about these medicines. Next. You've all heard someone say, you're feeling under stress, take a Xanax. Wonderful. These are medicines that should be used in the short term only, right? They can be addicting. They're helpful in very temporary conditions. Rarely will a patient be on this for a long time. And then we have a whole host of medicines that are great for sleep. Really, they're not. In every study looking at medicines like Lunesta and Ambien, what's wonderful about them is you sleep about 15 minutes more. But they have something unique about them. They essentially cause amnesia for the 8 hours after you take it. So you don't remember you had a bad night's sleep. Next. So let's talk about side effects. Everything has potential side effects. If I have OCD, I'm very familiar with that. I'm not sure I'm ready to cross that street. A car might come. I may get hit by a car, right? So that's a side effect. Right? I may pick up a glass of water and drink it and spill it on me. That's a side effect. Okay? Most side effects are time limited, are manageable, are reversible. Sometimes a side effect may require the addition of another medicine to help control it. Serious side effects are rare. Unfortunately, as part of any approval process, I, as the Hirsch pharmaceutical company, have to list every possible side effect, whether it happens 1 in 100,000 or 5% of the time. And that means if I'm a nervous person and I get that from the pharmacy, I'm never going to take any medicine. I'm never going to take any food either. Next. So, just a moment of witticism, if you will. I think you're afraid to be happy, Charlie Brown. Next slide. Don't you think happiness would be good for you? I don't know. What are the side effects? Next. So, people can be frightened about medication. It will change my personality. And the truth is, wearing glasses changes my personality. Without glasses, I bump into everything. So the right medicine brings the personality out, as opposed to changing the personality. It will have bad side effects. We talked about that. I will get addicted to it and will not be able to stop. So most of these medicines, in fact, really have no addictive potential. The stimulants have small addictive potential, one of the least addictive of all the addicting medicines. And sometimes we can't stop it because they're chronic illnesses, right? And that means if we stop it, it may come back. Sometimes therapy can actually treat and cure, especially when it comes to some anxiety disorders, but not everything. Why can't I use something natural? So we talked about that for a moment, okay? One of the most effective natural treatments is intense exercise. As soon as I say that to anybody who asks about natural, says, can't I do something easier? It means that I'm crazy and will never be normal. And when people say to me, I'm worried about being crazy, I say, if you're worried about it, you're not crazy, right? And in fact, medicine normalizes you. It really helps you. Would you rather be sitting and being in bed and not being able to get to work or get to a shir or get to kollel, but not take medicine and then sitting there and being functional? I'll never be able to get a shidduch. And the truth is, this is an issue in our community, right? But I will tell you that I keep a track. Over the 45 years I've been working, I've successfully spoken to 145 potential in-laws. And I'll tell you one quick story. I treated a young woman with a severe illness. She came out the other side doing beautifully. I get a call from her. She says, you know, my prospective in-laws and my prospective husband want to meet with you. And they come into my office and they have a long laundry list of things they want to ask. And this and this and this and this. And they look and say, we don't know, we're not sure. I said, that's okay, because I'm not sure either. I have a long list of questions I need to ask you. And the prospective voice, I'm not sure he's good enough for her. They now have 6 children. And the last one, next. Okay, so I think I won't go through this. Why are you important? Because you are the first contact often of someone who is worried about their own mental health or someone else's mental health in their family or community, and they're looking for your guidance. And that's why I think Dr. Schwartz and others have developed this. Thank you.
Take a few questions?
I'll answer questions. If I don't know the answer, I flip a coin.
Maybe I'll take a few questions.
Someone's taking medication, so like you mentioned, a lot of them sometimes are very effective. Baruch Hashem, I don't need the mic. They're very effective. Does it have to come along together with therapy, or they could just they're taking the medicine and now they're functioning? I've heard that you're supposed to take the meds and go for therapy at the same time. Could you help me with that?
So I think this is again, therapy provides something that medicine can't. Therapy provides skills, right, and understanding, insight. So if I have, let's say, anxiety, the medicine can quell my anxiety, but it's sitting in there beneath the surface. And if I can learn how to negotiate that, if I can face my fear, if you will, if I can learn how to cope with it, then I might be able to lower medicine. For some symptoms, ADHD, for example, the medicine helps 80%. For someone, it might be enough. But for others, I need to figure out how to be better organized. I need to think about how to communicate better. So getting those skills are important. So, and medicine, right, for some people, medicine works remarkably well. In the same way, and again, I want you to think about this as if you were thinking about a medical illness, right? The diabetic will do better if they lose 30 pounds no matter whether the insulin is helping or not. Plain and simple. My blood pressure medicine, it's helping. But you know something? If I lose 10 pounds and cut out the salt, it'll help even better. So therapy is always welcome addition. Not everybody is ready for it. Not everybody wants it. We can't force people into therapy. We can't force people into treatment. Yes?
Got pregnant now. So she says she's afraid it's going to affect the baby. What can you say about that?
So this is a question that comes up all the time, right? You have a newlywed, they want to get married, they got married and now they want to have children. And so Dr. Schwartz has made it clear to me that none of us are expert in everything, and I'm not an expert in what we call reproductive psychiatry. What we know is that yet medicines can potentially affect the baby, but not all medicines, number one. Number two is that some illnesses affect the baby even worse, right? And so we have someone who develops mania or psychosis during the pregnancy. That's much worse than being on any medicine. You know, so yes, I think this is something that we weigh carefully and we consider on multiple levels. What is the risk with medicine? What is the risk without medicine? Yes?
What about psychedelics? Ketamine?
Right. So we have a whole new class of treatments that are psychedelic medicines, right? What's hallucinogens, LSD, psilocybin, magic mushrooms, ketamine. There is an emerging science that suggests that ketamine may be helpful for the acute treatment of severe depression. At the same time, ketamine is a highly addictive substance, and I think the science has not kept up with the politics, if you will. It's the same thing, by the way, with marijuana. Suddenly it's everywhere. Everybody's getting CBD. They're giving it to their babies to sleep. What we know is that marijuana is particularly toxic to the adolescent brain, particularly toxic to the adolescent brain. And teenagers who take marijuana have a greater risk of becoming psychotic and schizophrenic. So I think we have to be careful. The studies are being done. Ketamine, we've got some approvals for. We need to think about it. It's not something that you can stop so easily, and I have not seen great success with it. That doesn't mean it doesn't help everybody, but it's one more thing in our pocket. In the same way, things like ECT and transmagnetic stimulation and others that we use are there and available, but we need to think, for this particular individual, for this particular issue, what is the right choice and treatment? Yes?
If someone whose only point of reference is, let's say, having taken caffeine, and we feel a little bit different when we have some caffeine, and we never tried psychedelics, these other medications you're talking about, how different does it make someone feel? What's the experience like?
Okay. So, yes. So the question is, what is the experience, the internal experience of someone taking medicine? What does it feel like? So it depends on the medicine, right? If I'm depressed and I'm sitting there and I'm ruminating and thinking in my head, I'm a terrible person, I can't do anything, there's nothing, I don't want to live, well, I'm going to feel better, right? I'm going to suddenly start to feel more energetic. I'm going to suddenly realize I woke up today and didn't have those thoughts. When it comes to medicines for ADHD, suddenly I'm able to sit and focus and learn, and my parents not yelling at me. So for most medicines, it's not necessarily a physical difference, but it is a change in suddenly things are different. And it does. When I say suddenly, I don't mean like overnight, but suddenly, gradually, you suddenly realize, hey, I'm feeling better, right? The anxiety isn't as intense. I'm not washing my hands as much. I'm feeling better. I'm feeling like I can actually get to work today. I'm feeling like I can go to yeshiva this morning. Yeah. I mean, a lot of people, the question is feeling normal. I'm not sure what normal is, but feeling functional, right? That's the goal. What we have for every person is to be able to function, and that's what we're looking for.
Elya Brudny, when he mentioned things changing, he mentioned personality disorders. That was his example. Do you give any medicines for personality disorders?
So, personality disorder is rather complex, and so personality disorder is a disorder in which the individual has little insight and is a pattern, a long-standing pattern, if you will, of a particular kind of behavior. And there's some evidence that medicines may be helpful, but probably therapy is much more helpful in this respect. Yeah, because it's not something we would routinely, I mean, again, for many people with personality, they also have another condition. And so we might provide medicine for the other condition, and sometimes it can reduce some of the symptoms of a personality disorder. And it's sometimes hard to tease apart when you have something that's both a personality disorder, for example, and a chronic depression. Is it a chronic personality disorder that looks like depression, or is it chronic depression that looks like a personality disorder? And so we need to tease that apart. Yes?
If somebody is a legal adult,
Oh, I'm sorry?
How do you make determination whether to send someone to a psychologist for therapy or to a psychiatrist for medication?
So I tried to kind of give that little overview at the beginning. The issue really has to do with intensity, severity, chronicity, and of course, partly it's, what does the person want? My preference is, unless there is a crisis, that let's start with a little therapy. Now, I don't want somebody to be in therapy for 4 years before somebody comes back to me and says, oh, I think you should be on medicine. I think what we want to be able to do is say, let's reassess in 3 months. Have we moved the needle? Has this individual seen therapy as helpful in seeing some movement? Right? Again, if the person is not functioning at all, if the young man has been thrown out of 3 yeshivas, if the wife is ready to throw the man out of the house, we're going to go in there like gangbusters.
if someone is a legal adult where the parents no longer have control and the individual refuses to take medication, is there a process to, I don't want to use the word force, but to somehow get them help?
You raised the most difficult question in our field, right? For many illnesses within the psychiatric realm, what is somewhat unique and different than perhaps in the medical realm is that often there is a loss of insight. I don't have a problem, right? It's not a problem. I don't have a problem. I'm fine. There's nothing wrong with me. And in that case, convincing someone to get treatment is much harder. Sometimes we can do things like, listen, you're not staying in my house if you're not going to get treatment. There are laws, if someone is violent, that you can get a court order for treatment, but it has to meet certain criteria. In New York and in New Jersey, there are specific laws that are in effect. But other than that, it becomes problematic. And I see it especially around individuals with bipolar disorder, for example. They become manic. They like the feeling of being manic before they start to get so bad they end up in a hospital. Then they think they can control it and they won't take medicine. And it goes back and forth. I just had one individual, it's the 4th time he's in the hospital, he comes out and says, I know, I figured it out now exactly what I'm going to do, so I'm not going to get hospitalized next time. And I know it's going to happen again. And it's unfortunate, and it's usually that, that young adult time period, right?
So I'm going to read, this is a question from the Zoom. We had over 120 Rabban from throughout the country on the Zoom. I saw a study that SSRIs are just as effective as placebos. Is that true? And if so, is it not a medicine?
Okay. So this is a very good question and a very complex question and answer. So for very mild symptoms, placebos work pretty well, right? And so medicines like Prozac work about the same. But for more moderate and severe depression, it works much better. There are some complicated issues around studies that have been done in where studies are done in 150 sites around the country or the world. And what happens is, in those cases, the mix of patients is much more superficial in terms of the symptoms, and it appears that placebo is doing a pretty good job. But in fact, when we look carefully at studies that are funded by the National Institute of Health, antidepressants and other medicines are far superior than placebos.
I'll read another question from Zoom. Have you seen any type of therapies that are better than others, and where you have seen more success than others, was just about what works for that specific person?
So again, I'm not the expert in therapy, and we're going to have perhaps Dr. Schwartz will answer that at some point. But I think, look, there are two components to therapy. One is the connection that you have with the therapist, which is critically important, right? Because if I go to a therapist and I don't think highly of them, or I don't have a connection, or the therapist falls asleep on me, that's not going to work. But the second is, therapy at best, in best of circumstances, should be relatively time limited. And one of the things we want to do is we want to build understanding, but we also want to build skills. Often, one of the issues in why we're struggling with functioning is that we don't understand how to move past it because we don't have the right skills or the right understanding or the insight. And so that's where treatments like CBT work so beautifully, because it really helps me identify what's going on and how to, if you will, take my weapons out and figure out and get a skill so if it pops up again, I can kind of bang it back down. So I think there are a whole host of therapies out there, and sometimes we can target it, right? So someone who has a substance abuse, there are very specific therapies for substance abuse. For trauma, there's very specific therapies for trauma. But at the same time, we start with what is the diagnosis? I'm going to get on my 30-second bandwagon. Suddenly, trauma is everywhere. If my fourth grade Rabbi yelled at me, that's why I'm the way I am. It harkens back to what used to be the old psychiatry, that we knew exactly what caused illness, which was mothers. Everything mothers did was wrong, and we blamed it on them. We now know, like the rest of medicine, that we don't know what causes most illnesses. But now we've gotten to this idea that, everything is due to trauma, and we've got to be careful about that. Because moms and dads, parents, grandparents, by and large, are doing the best they can. And no parent is perfect. And that's why they're human beings.
Last question.
Do people grow out of ADHD?
Some do, but not everybody. When I was in training, we used to believe it stopped at adolescence, but that was because we weren't asking the right questions to the right people, right? We didn't speak to teachers anymore. And it was interesting, there's a long-term study by a guy named Russell Barkley, who took a look at kids longitudinally over a lifetime. Childhood, ADHD, adolescent, ADHD, young adult, no longer ADHD, older adult, ADHD. Why? Because in the young adult range, there was no one else in the surroundings to ask the question. Came an adult, we speak to your spouse, and suddenly she says, oh my God, do something, right? So for many people, this is a lifetime disorder. Again, the environment makes a difference. If I have ADHD, I don't want to be an actuary. I don't want to be reading legal documents. I'd rather be someone who's in sales and moving all the time, right? And so I think that's where we can help, and what therapy can also do is help guide people in thinking about how best to maximize their potential given whatever limitations there are. Thank you very much, everybody. Have a good night.
Just like to thank one more time Dr. Schwartz and Dr. Hirsch for their tircha, for everything they've done. I'd like to thank again Dr. Chaim Neuhoff and Zecher Nishmas, his father, David Shleima, Ber Meir Zatzal, and I'd like to thank Reb Yeshua Greenspan, the Manal of the Medical Halacha Division, Yeshua Grunwald, the Rosh Kollel of the Medical Halacha, and Reb Binyamin Cantor, who is responsible for setting everything up, all the logistics and the Zoom and the Shilas, and just a shout out to Reel to Reel for putting everything together. Thank you very much. Still, we can make a marv for those interested in the next room. It's a little drop early, but it's if there's a bikush, then and the Mitzvah Hashem next week, same time, 7:30. Bezos Hashem. Who's presenting next week? Cool. Yeah, we'll see the sign. Thank you very much. Shkoyach.